The Appropriations Subcommittee on Labor, Health and Human Services, Education, and related agencies will come together. This is come to order, and this is always a good hearing for us. I think in the 4 years that Senator Murray and I have worked on this committee together, we clearly have made this one of our priorities, and glad it has been. We've increased funding by $9 billion, a 30% increase over 4 years, and hopefully we're not done with that process yet. But hearing what you're doing with that money always helps encourage us to not only make those dollars available, but even more. We've seen real progress in vaccines from Ebola to Zika. We've seen the development of blood tests to detect different kinds of cancer earlier than we had been before. First ever drug use specifically for postpartum depression has been developed during this period of time. Obviously, what's happened in immunotherapy, which at our first hearing was something that had to be explained to all of us and even a few of your colleagues as it was developing to in the amazing way it has already. I think we've seen ways that you've found to encourage young researchers, and hopefully we'll be able to hear a little more about that today as well. In my state of Missouri, research has demonstrated that interactive therapy can reduce rates of childhood depression, discovery of an enzyme responsible for the spread of cancer, and we've seen research supported that aimed at improving the scaling up of immunotherapy and how to make that more available in a more affordable way for more people. I'm disappointed, of course, that the 2020 budget request would cut the agency by 13%. I'm confident that this committee will not do that, but we'll talk to you today about the reasons that we should continue in the direction we're in rather than head in another way. Deeply concerned about an issue that I've seen develop, and I hope, Dr. Collins, you have a chance to talk about that too. It's something that the research community needs to take more seriously, and that's foreign governments are initiating systematic ways to influence our research and, frankly, to take advantage of our research by stealing it. There's a Chinese government program to recruit NIH-funded researchers to encourage them to steal intellectual property, cheat the peer review system, establish shadow laboratories in China, and help the Chinese government obtain confidential information about NIH research grants. That can't continue to happen, and I look forward to hearing your discussion of that issue. Obviously, there is an important balance here of protecting our research from both foreign threats and other kinds of piracy, and having the kind of collaborative environment you want to have to bring the best people into that research community you can. I know that's a challenge, and I've seen some challenges that you've faced even recently on that topic of who should be there and where they should be. But we've benefited from them. They have benefited from us. This is a system that has worked, and we need to be sure we continue to protect it. Not everyone is well-intentioned. I know there's an ongoing FBI investigation, and that investigating specifically what the Chinese government's trying to do to undermine our research structure. This is a serious threat to all of the things that make that structure work. The NIH Advisory Committee has recommended several steps, including implementing a broad education campaign about the requirements to disclose foreign sources of funding and developing enhanced cybersecurity protocols. And while I appreciate those recommendations, I think NIH has to be sure that the research community is fully aware of the threats and, more importantly, how to combat those threats. NIH has sent only one letter to the community on the subject, I think, but I'm going to let you talk about that a little more, either in your prepared remarks or later in questions. It's a vulnerable environment. It's a critically important time to look to the future number of individuals that are part of the so-called 1,000 Talents program may be few. I think we shouldn't just assume that that's the only program out there trying to do exactly the same thing either. So, Dr. Collins, certainly I'm pleased with the relationship you've had with this committee, with your leadership. I admire the team that you and your colleagues have put together. I'm excited about the opportunity of the moment and glad you're here with us again today. And I'd like to turn to Senator Murray for her opening comments.
Well, thank you very much, Mr. Chairman. Dr. Collins, good to see you and all of your team. Thank you to all of you for being here today and for the work you are doing. The National Institutes of Health is perhaps the best example of an issue where members on both sides of the aisle have been able to come together. We have repeatedly worked in a bipartisan way to provide increased investment in research that improves the health and well-being of people, invests in our local communities, and supports our country's continued leadership in science. NIH is the largest funder of basic research in the world, and I'm very proud that Chairman Blunt, thank you, and I and others on this committee have been able to increase its budget by $9 billion over the last 4 years, despite opposition, by the way, from the Trump administration. Now, we are here today to talk about President Trump's latest budget, and it stays true to form and proposes severe cuts across the spectrum of healthcare activities. In his budget, President Trump proposes steps that would undermine healthcare protections for 130 million people in this country living with a pre-existing condition. It strips healthcare away from tens of millions of people, and we should not forget he is arguing in court for a ruling that would do all of that and more. President Trump's budget proposes slashing the Centers for Disease Control and Prevention, including their work on birth defects and disabilities, their efforts to combat antibiotic-resistant pathogens and emerging infectious diseases, and more. It slashes funding for the healthcare workforce training programs at a time when our nation is facing a healthcare provider shortage, particularly in our rural areas. And it proposes eliminating funding for the Teen Pregnancy Prevention Program and cutting funding for rural health and maternal and child health. And at a time of remarkable possibility in medical research, a time where we can and should continue leading the world in medical discovery, the Trump administration wants to cut funding for NIH. President Trump's budget offers one small step forward for pediatric cancer research and a marathon sprint backward for everything else. While he proposes increasing pediatric cancer research by $50 million, he proposes cutting $100 million, twice that amount, from diabetes research. He proposes cutting $300 million, 6 times that amount, from Alzheimer's research. And he proposes cutting over $1 billion, 20 times that amount, from efforts to discover treatments for every other kind of cancer. In fact, for every new penny President Trump proposes for pediatric research, he proposes cutting $1 from NIH. He would cut funding from just about everything, which would mean delaying or even missing opportunities to find treatments and cures that could save lives, like a universal flu vaccine or a vaccine for HIV. President Trump's damaging budget is wildly out of step with the sentiments of Congress, thankfully, and the American people, and I feel confident working with our chairman that we will once again reject it. Now, I do want to say that with that support for NIH, however, comes the expectation that NIH will lead in all of the fields in which it is involved, including setting the highest standards for the behavior of the research community it funds. Last summer, the National Academies of Science, Engineering, and Medicine released a report that found sexual harassment is common in all 3 fields. Dr. Collins, you and I have had numerous discussions about this. The report found that almost half of women in medical school or enrolled as a graduate student in a college of medicine, and more than half of women faculty in academia reported having experienced some form of sexual harassment. The academies recommended federal research agencies require institutes to report when people on grants have violated sexual harassment policies or have been put on administrative leave due to harassment allegations, a recommendation the National Science Foundation has since adopted. NIH needs to step up and demonstrate greater leadership in holding its partners and extramural grantees accountable as well. It is not acceptable for NIH to defer to its grantee institutions or other agencies to address harassment rather than actually requiring them to report when it happens in research settings or by researchers funded by NIH grants, especially when NIH's funding gives the agency such sway with the research community. Harassment undermines scientists' and researchers' professional and educational attainment and erodes the integrity of the research enterprise. It makes survivors feel inferior or that they don't belong, and it drives promising young scientists away from research at great cost to our nation and our scientific advancement. I expect more from NIH on this issue, and Chairman Blunt and Dr. Collins, I'd like to work with you both on direction that requires NIH to take meaningful action to address harassment that occurs in both intramural and extramural settings, including implementing recommendations from the Academy's report, some of which the National Science Foundation has already done. Thank you, Mr. Chairman.
Thank you, Senator Murray. As Senator Murray pointed out, the committee's worked hard on this together. Senator Durbin, Senator Alexander, great advocates, along with Senator Shaheen and Senator Moran. But the two people at the top of the committee have also been incredibly important in encouraging us to move forward. I might point out that it's not just the current budget. The past administration actually proposed cutting NIH research a time or two and never proposed, as far as I know, increasing it. At least it didn't get increased. So we've sort of had a bipartisan determination to correct a bipartisan failure to move forward for a long time, and we're going to continue to do that. And one of the reasons we'll be able to do that is the great leadership of the chairman who joined us today. And Chairman Shelby, do you have some comments?
Thank you. Thank you, Chairman Blunt, Ranking Member Murray. First, I'd like for my written statement to be made part of the record.
Without objection.
And I'll be very brief. I want to tell you, and I agree with both Senator Blunt and Senator Murray, this is an important hearing. What you do is more important than most what we do in America. I'm not interested in cutting your budget. I'm interested in increasing it, so are they. And we're going to have a big struggle this year dealing with the budget, but I think this is a great investment for America, for the world, for humanity, what you do. Sitting at the table here, all of you distinguished in your own right. We're fortunate to have you, have your dedication, and we're going to stay with you, and we're going to continue to do it. I believe it's not only a financial investment, which is good for the economy, it is the leading scientists, the cutting edge of scientific research that you had, and we all benefit from it immensely. Thank you, Mr. Chairman.
Well, thank you, Chairman. Again, Dr. Collins, welcome to you and the directors of several of the institutes that are with you today. We look forward to hearing what they have to say as well, but if you'd like to start with your opening statement, this would be the time to do that.
Well, thank you. Let me introduce the people at the table. On my left, your right, starting over at the end, someone well known to this particular panel of senators. We estimate this might be about his 400th hearing. Dr. Tony Fauci, Director of the National Institute of Allergy and Infectious Diseases. Next to him, our Director of the National Institute on Aging, Richard Hodis. Then next to me, Dr. Griffin Rogers, Director of the National Institute of Diabetes, Digestive, and Kidney Diseases. On my right, John Lorsch, Director of the National Institute of General Medical Sciences. Next, Doug Lowy, who has stepped back into the role as now Acting Director of the National Cancer Institute, as Dr. Sharpless has moved over to FDA just in the last few days. And then on the end of the table, Dr. Nora Volkoff, Director of the National Institute on Drug Abuse. And I'm honored to have these colleagues with me today for what I hope is going to be a really important exchange of ideas and information. So, Chairman Blunt and full committee chair Shelby, Ranking Member Murray, members of the subcommittee, I want to thank you most sincerely for your strong and consistent and bipartisan support of NIH. In FY19, we received a most welcome increase of $2 billion, enabling us to continue our mission of turning scientific discovery into healing and hope, and we'll have a chance to tell you about some of those things in the course of this hearing. I take very seriously the comments that were raised by the chairman about foreign influence and by the ranking member about sexual harassment. These are issues of incredibly intensity and importance, and I hope we can discuss some of those in the course of the questions. But I wanted to introduce you today to just a few of the millions of people who over the years have made medical research progress possible by volunteering to take part in NIH-funded research. Instead of focusing on the researchers, I'm going to focus on our really important partners, the people who take part in these clinical studies, and tell you something about 3 examples of them. Let's begin with Richard Hochfelder. So 6 years ago, this retired aerospace engineer had a blood test called hemoglobin A1C that showed that he was at high risk of developing diabetes, a pre-diabetes diagnosis. So he took some preventive steps, like cutting down on carbohydrates and exercising more to get his health back on track, and that worked really well. Now, he could have kept that success to himself, but instead he decided to help others, and he joined NIH's All of Us research program, which is building an unprecedented resource to explore what health approaches work best for each individual and why. This is precision medicine on a scale we've never attempted before. We're making great progress toward enrolling our goal of 1 million or more people, and you can see from the graph where we are in less than a year. More than 200,000 people have in fact begun enrollment, and about 50% of those are from traditionally underrepresented racial and ethnic minority groups, because we want very much to have an opportunity with this resource to understand health disparities. It's a very diverse population. Now, all the information that they contribute of various types will go into a highly secure database that researchers can get access to make discoveries. Success is going to depend on involvement of people from all walks of life, so we encourage you to join too. And all you have to do is go to joinallofus.org, and anybody in our country can join this effort. And we do hope by the next 3 years to take this already 250,000 and bring it to 1 million people. This is unprecedented. It's already the largest study that we've mounted in a very long time, and we're only a quarter of the way there. Let me turn to another example of somebody who's volunteered to help us with research. This is Frank Stevens. Frank belongs to a community with unique biological characteristics that's been offering to volunteer for research for years, but too often hasn't really had that opportunity. I'm talking about individuals with Down syndrome. We need to do better for them. Frank actually did testify before Congress in October 2017. That's where this picture is taken. Now, Down syndrome usually results from having an extra chromosome 21. Each year, about 6,000 babies are born with this condition in the U.S., and the average lifespan has doubled in recent years. But these folks still face significant health challenges. They include an increased risk of heart defects, of leukemia, of immune problems, of autism and Alzheimer's disease. On the other hand, interestingly, Down syndrome individuals have a lower risk of coronary artery disease and a lower risk of solid tumors, even when you age match. We don't know why that is, and it would be very important to figure that out. So because of this, studying Down syndrome may hold the key not only to helping those who have the condition, but also to understanding common diseases in all people. And this is a good example how rare diseases can inform us about things that go well beyond that particular condition. NIH is stepping our efforts to do just that. This should come as good news to Frank and his mom. You see here vacationing, and his mom, Cornelia, actually herself has already shown signs of Alzheimer's disease. Frank faces a greatly increased risk of that because of his Down syndrome, but his mom already has it, and he wants to try to help her as well. As Frank once put it, my extra chromosome provides a blueprint for medical research that could reveal answers to this heartbreaking disease. Well, speaking of heartbreaking diseases, I told this subcommittee last year that we might be on the verge of a cure. I used the C word, cure, for sickle cell disease, a life-threatening genetic disorder that bends red blood cells into a sickled shape because of a mistake in the gene that codes for one of the hemoglobin proteins. And they're bending then into this sickled shape that blocks blood vessels, causing excruciating pain in a sickle cell crisis and damage to organs, which sadly shortens the lives of people with this condition substantially. So we talked about last year, maybe we're on the brink of something. Today, I'm thrilled to say I think we have reached a remarkable milestone. Let me introduce you to Janelle. Janelle Stevenson is one of the brave research participants who's helped make this happen and whose story was recently featured on CBS's 60 Minutes. Throughout her young life, as you can see, she was often hospitalized, even at Christmas. You see there with Santa Claus next to her bed, and has experienced over the course of her 20 years just about the worst pain that a human can imagine from these crises. But she decided to take a bold step for herself and for others with this condition and signed up for a gene therapy trial at the NIH Clinical Center. In this trial, her own bone marrow stem cells were removed, modified to compensate for that sickle mutation, and then infused back into her body, where they began producing healthy red blood cells. The transformation has been pretty incredible. Here's Janelle sitting alongside her father, Ray, wearing her white jiu-jitsu uniform. And here she is. Remember, this is somebody who was pretty much almost bedridden before this procedure.
Move, switch your arms and move. And
Remember, Janelle used to struggle just to walk up a flight of stairs.
And you fall. Boom.
And a fall like this would have landed her in the hospital.
Boom. Yeah. Good job, you did it. Bam.
What was going through your head as you were watching Janelle being thrown down to the mat?
I was just saying, thank you, Lord. Thank you for medical science, and thank you for giving her a new life.
New life, indeed.
So our nation needs a lot more stories like this, but that one certainly is heartening to anybody who's wondered, are we going to come to an answer for that first molecular disease, sickle cell? We've known about it for more than 100 years, and now a molecular cure for that molecular disease in a very rigorous research protocol, and the treatment was challenging to endure. But you can see this is working. The promise is now real for the nearly 100,000 Americans who suffer from this devastating disease. So we need a lot more stories like this through the generosity and courage of people like Richard, Frank, and Janelle, along with your strong and sustained support. NIH research is making it possible for these kinds of stories to emerge every day, and the world can look forward to a healthier and happier future. So thank you, Chairman. We welcome your questions.
Thank you, Dr. Collins. Why don't we talk a little bit about the efforts you've made on the concern about foreign involvement, about duplicate labs in other countries, information being shared that shouldn't be, and then what we're going to do about it.
I'd be glad to do that. We are deeply concerned about the evidence which has been growing and which we've become increasingly aware of over the course of more than a year, that there are instances, egregious instances, where our funding of grants in this country is being taken advantage of by individuals who are not following the appropriate rules. This is utterly unacceptable. We have had multiple opportunities to interact with the FBI, who have been investigating this vigorously. Some of this is classified information, some of it's not. And as a result of that, have uncovered what has now led to more than 55 investigations that are ongoing of institutions where we believe there may be investigators who are double dipping, receiving foreign government money without disclosing it, or in some instances diverting intellectual property that was rightly the property of the institution where they are working to China, or maybe most egregiously at all, because it violates such an important principle for us, taking grants that they're asked to review as part of the peer review process and distributing those to another country even before those grants have gone through the full review process, giving therefore an opportunity for somebody else's ideas to be stolen. Knowing the seriousness of this, I did something unprecedented and wrote, first time since I've been NIH director, to every one of our grantee institutions, and that's more than 10,000, a very strongly worded letter saying this is an issue they all need to take with great seriousness. And they, if they're not aware of what their own faculty are doing in terms of these kinds of relationships, need to begin to find that out. I think there was initially some surprise and maybe even denial that that could be happening in these institutions. I think we are past that now, and we are now seeing statements from some of those institutions very strongly worded to their own faculty saying, we realize we have a problem too. There are increasing instances where faculty members have been fired, have been asked to leave the institution, many of them then returning back to their previous foreign base. And I should say, while China has certainly been mentioned a lot, this is not only China. So actions are going to be being taken, and you will see more evidence of that in the press, particularly in the coming week or two to show just what is now necessary in order to respond to this. We will not rest until we've looked at every possible example. We have to depend on the universities as our partners in this, but we are driving this process as vigorously as we can.
In those 55 instances, how many different institutions would that involve?
That's 55 institutions.
55 different grantee institutions.
Yes. And basically, we are triggered by noting in a grantee that there is a publication that comes out that seems to involve a lot of authors and a lot of other institutions that were not mentioned in their grant application. Now, maybe that's an appropriate collaboration. I'm not going to tell you that every one of these investigations is going to reveal something bad happened, but some of them will.
Well, we clearly benefit from having people from other countries here, to have their skill level here. Frankly, I think we benefit to have them, if they want to stay here,
Absolutely.
to let them stay here. It's difficult to look at this from the point of view of where somebody comes from, but no matter where they come from, if they're involved in this, we're going to have to obviously be at a higher level of on guard than we have been.
Mr. Chairman, I'm totally with you, as are my colleagues. I'm glad you raised, though, the concern, though, that we not carry this to the point where anybody who's a foreign national begins to feel like they're under suspicion, even if they're honorable contributors to our workforce, because almost all of those folks are. We need to be careful that we don't step into something that almost seems a little like racial profiling. I think Chinese scientists working in the U.S. have already written some letters to Science Magazine to express their concern about not being swept into this same framework where everybody's under suspicion, because the vast majority of these folks have been incredibly important and honorable contributors to our workforce.
Now, and there's a research synergy that you achieve by bringing people together from
Absolutely.
Totally different preparation styles and everything else into that research moment, I think.
Yep. Diversity contributes to productivity in every way, and all kinds of diversity. That's true, including gender diversity, including people from different socioeconomic backgrounds and from different countries.
Yeah. I'm sure we're going to have lots of questions. Let's try to stay with the 5-minute time, but anybody that wants to stay beyond their first round, we will get to as many questions as we could possibly get in between now and the time we're done. Senator Murray.
Thank you very much, Mr. Chairman. You know, many research organizations are now exploring the best ways to create research data commons. Private sector communities of companies and extramural research institutions like Science BioNetworks, Penn State, and Google's datacoms.org have demonstrated success, while other federal agencies are already further along than NIH in successfully establishing data commons, like the National Science Foundation Big Data Innovation Hubs. It's really important that we learn from them as well as from some less successful attempts at driving data infrastructure like CA Big, which saw very little traction in the community and was widely criticized. So, Dr. Lorsch, let me start with you. What is NIH doing to avoid reinventing the wheel, and how is NIH planning to leverage data commons work that's already being done extramurally?
Thank you very much, Senator. That's a very important question. If we can connect disparate types of data, so say data from the Jackson Heart Study with data from Dr. Hodis's Alzheimer's disease databases, the power of that could be enormous in terms of generating new ideas, new connections between these diseases. So in that case, between cardiovascular health and dementias, for example. That might lead to new ideas about treatments that could be possible or earlier detection strategies. This is what we call interoperability, making data that's in different languages, essentially, able to talk to each other so the scientists can use that data for these kinds of discoveries. We're working very closely right now with our partners in academia as well as experts in the tech industry, particularly through the STRIDES initiative, which is an arrangement with Google and Amazon that we have right now, to develop ways to connect the high-value data sets that NIH has, the Jackson Heart Study, for example, and Alzheimer's data together to create this interoperability. We're definitely looking at past examples, both successful and unsuccessful, to help guide us, and we're definitely taking a lot of input from experts, particularly in the tech industry, through that STRIDES initiative.
Okay. Yeah, Dr. Collins, what is the agency doing to really encourage and support data science training in other scientific fields beyond those like genomics and neuroscience, which really have embraced this?
Appreciate that you're raising this issue, and John Lorsch has been very much a leader in this space. You see here our website, which will show you our strategic plan for data science, which has been a way in which we've tried to put together a lot of ideas. And I totally take your point about not reinventing wheels that have already been tried, either successfully or otherwise. So I think we're pretty well invested in that. And certainly a big part of this is training. We are seeking to bring more fellows to NIH, to bring the skill sets that exist in Silicon Valley and get them excited about biomedical research, because that's where a lot of the talent is. We're recruiting a chief data strategist, probably somebody from the private sector, to help us with that kind of culture change and recruiting of talent that we know we need. We need our bench to be a lot deeper. We aim to get it there.
Okay, good. Thank you. Really appreciate it. Dr. Lowy, let me turn to you. While Congress has been providing the NIH, including the National Cancer Institute, with more funding each of the past 4 years, the odds of securing a grant from NCI have actually been getting more difficult. Can you tell us what is driving that trend and what its significance is, and do you expect it to continue?
Thank you very much, Senator Murray. Thanks to the generosity of Congress, we have received an increase in our appropriation for the last several years, approximately 17% through 2018 to the regular appropriation during that time. During that time, we have increased the number of awards made for investigator-initiated research by about 20%, the number of new people in the award system and the NCI by 20%. And so this is, I think, very much in line with what you and your colleagues have had in mind. On the other hand, we have had, over that period, a 50% increase in the number of grant applications. And so it has not been possible to keep up with the number of awards that we would like to make, although we're very pleased we have been able to make more. It has led to the success rate for investigator-initiated research going from 15% down to a little bit below 12% during that time period. And we certainly hope that we will be able to increase the success rate going forward. For example, this year we are planning to put in more money to the RPG pool than even with the generosity of Congress has added to the NCI regular appropriation.
Okay, thank you very much. Appreciate that.
Senator Shelby.
Thank you. Dr. Collins, you've previously said that the private sector research outspends public sector research 3 to 1. 3 to 1. To prevent overlap, investigators in the public and private sector, I believe, should coordinate research where they can so that efforts would not be duplicated so much. I know there's a Accelerated Medicines Partnership, AMP, going on. You've talked about it before. Would you give us an update on this, and how are we working together to get the good results?
I'm happy to talk about that. Yeah, I think it is a great opportunity to bring the best and brightest skill sets in terms of scientists and also the areas of expertise. NIH is in the basic science and translational arena, but we don't make pills, and the industry does. And we have to figure out how to do that handoff so that this ecosystem really flourishes. I get invited each year to a meeting of the heads of research and development of the largest pharmaceutical companies. We just met this past weekend. And we've developed, I think, a very functional working relationship there to identify opportunities for shared collaborative pre-competitive efforts. And AMP, that you just mentioned, the Accelerating Medicines Partnership, is one of those, which I think has been particularly successful. This allowed us to come together around several diseases, and that includes Alzheimer's disease and rheumatoid arthritis and lupus and diabetes, and basically to work together to identify whether there were areas that we could, as a group, do that neither could do alone, yet make all the data available. We have to do that. We're NIH. In those projects, which are now almost 5 years along, we have met every milestone, and everybody who is involved would say we have accelerated the progress in finding new treatments for those diseases. Every one is a little different in terms of the particular science that's being supported. My colleagues here are a part of that. So Dr. Rogers oversees the NIH part of the diabetes effort. Dr. Hodis oversees the part of the Alzheimer's effort. Dr. Carter, who's not here, the rheumatoid arthritis and lupus. And we've just started a new one on Parkinson's. And we're talking about a new one on schizophrenia, where we desperately need some new ideas. And industry, after being a little reluctant before, is now looking as if they could embrace that too. There's a separate project on cancer immunotherapy called PACT, which is a relationship we have with industry. So I think we're finding ways, obviously recognizing we have different goals, to make that happen. And that is a personal priority for me, to be sure we don't miss those opportunities.
What about cystic fibrosis? Where are you going there, and where do you hope to go?
Well, this is
come a long way.
This is also something I have a personal passion about, having had opportunity to co-discover the gene for cystic fibrosis exactly 30 years ago. And now to see, although it took 30 years, and I wish it had been faster, the emergence of highly effective triple therapy with very well-designed molecular-based drugs that looks as if something like 90% of people with cystic fibrosis are now going to have a treatment that allows them to live out what could be almost normal lives, which is an amazing thing to be able to say. It took a huge amount of work from NIH-funded resources to try to figure out exactly what the mechanism is for this disease and what kind of drug might work, and then a close partnership with a company called Aurora, which then became Vertex, and now here we are. And it is incredibly gratifying to see that for all those kids and families that have been waiting for this all this time.
Doctor, you've been very involved in the National Center for Advancing Translational Sciences,
yes,
and so forth. Could you elaborate on how NIH is implementing this program to address healthcare access and delivery in rural areas across the country?
So NCATS, the National Center for Advancing Translational Sciences, is one of our newest entities, and I have been very excited to see this emerge, trying to identify ways that we can help research projects that sometimes get stuck in the valley of death actually move across for benefit to people out in the clinics and the hospitals. NCATS also runs the CTSAs, the Clinical and Translational Science Awards, which is this network of 57 centers across the country. But we are aware that those are generally located in more urban settings, and there's an opportunity and a responsibility to reach out to rural communities. NCATS has out right now a notice of interest out there to think about how to link up in that way. One possibility is to link up with the IDEA states clinical trial research networks, which are also oftentimes more in an opportunity where there is a rural setting, and also to see if there's a way to work in the pediatric clinical trial network, which has also been put forward as part of the effort to deal with the opioids crisis. So we have a lot of connections here that are being built. There was a meeting at University of Florida to talk about this 2 days ago. I'm waiting to hear what the results of that were.
Doctor, lastly, could you explain how NIH determines funding levels for research within its larger funding number? Because all of us advocate for certain diseases that touch us and touch our friends and family and constituents in many ways.
In the minus 21 seconds I have, let me see what I can do to
I think I'm over.
to outline. It's a critically important question. All of us around this table work with that issue virtually every week, trying to be sure we have our priorities set. I might point you to the strategic plan that we put forward a couple of years ago, which tries to go through in a very clear fashion how those priorities get set. May I say we appreciate the fact that the Congress generally doesn't give us a lot of recommendations about specific disease areas, because we think science is in the best place to make those decisions along with what the public health need is. And that's what we try to do every day.
Mr. Chairman, could I just, not a question, make a request? Dr. Vickers, you've been invited to be the keynote lecturer, I'm sure all over the world, but in Birmingham and at the Lecture Academic Leadership, Medicine Academic Leadership Series. I hope if you can work that out, you'd go. You've been there before. They asked me to do this, and I told them I would follow their request.
I'll be there.
Okay, thank you.
So that's the right answer, I'm sure. Senator Durbin.
Once again, proving all politics is local.
Oh, yeah.
Dr. Collins, it was about 5 years ago when I visited the NIH, and you and I had a conversation which informed and inspired me about 5% real growth a year in funding on medical research. The education of a United States Senator is a daunting task, and I thank you for taking the time to explain to me how consistency is important as amounts. It is a new challenge to you in this day and age, to justify the amount that is being added each year. When I look at the record, and I want to give special shout outs to our chairman here, Senator Blunt, Senator Murray, who just in both authorizing and appropriating committees has been a national leader on the subject, and Senator Alexander, who is retiring, and I'm hoping that someone with his skill and determination will replace him to continue this battle. But since fiscal year 2014, we've seen a 30.6% increase in NIH funding, a 40.6% increase in Department of Defense medical research, and a 33% increase in VA medical research. The CDC, 7.4. I wish it could have been more because it's a deserving agency. But when you answer the question of the chairman about the integrity of the research undertaking and endeavor, particularly our concern about falsification of data or stealing of information, I think it really goes to the heart of this. Those of us who deeply believe in what you're doing and believe it's one of the most important parts of our public lives really need to count on you as well to join in proclaiming that integrity is not being compromised and money is being well spent. Our critics are going to be watching to find evidence to the contrary. Would you like to comment on that?
I couldn't agree more. Let me say, I appreciate your beginning your comments about this importance of predictable, steady trajectory for support. That has been such a source of encouragement, particularly to young investigators who are seeking to know whether they had a path for their careers. And frankly, things were looking pretty tough for them 6 or 7 years ago as we'd lost a fair amount of purchasing power. And now to have this 4 years in a row of a steady upward trajectory has changed the dynamic completely in the institutions that I go and visit, where the postdocs and the graduate students and the junior faculty are now really fired up about the opportunity. But you're right, this puts great responsibility on us to be stewards of every dollar of that. And if we find misuse of that information, to move swiftly to make sure that that is quickly stopped. And we are doing everything I think we can in that regard with help from our institutions to root out that problem. And I think we've made a lot of progress, but we're nowhere near done.
I'd like to get more specific and personal in this next question. Tuesday morning, a young man from Chicago named Brian Wallach and his wife Sandra came in to see me. A year and a half ago, 18 months ago, he was diagnosed with ALS, Lou Gehrig's disease. And they wanted to come and talk to me about their determination to try to spark more interest, more research, more focus on this disease. Sadly, the life expectancy of those diagnosed is not long, and they fear that many of the people who are the most passionate advocates will not be here long enough to fight the good fight and see good results. What can you say to the couple and others that face this particular disease?
This is a particularly critical and heartbreaking condition, as you well know. We have redoubled our efforts to try to take advantage of some of the newer discoveries to come up with clinical applications. There is a consortium now called CREATE, which is clinical research in ALS and related disorders for therapeutic development. We have been heartened by the success, which I think I talked to this committee last year, of a gene therapy for the infantile version of ALS called spinal muscular atrophy, which actually has worked quite well. And now the question is, could that same approach be successful, at least for some individuals with ALS where we know what the genetic mutation is, and there are families where that is the case. That is a big area of focus at the present time, but not the only one. So we at least now have a consortium to put all the ideas that we can come up with into this space. It's a very hard problem, but I think our chances are better now than ever to make some real forward motion and maybe even some breakthroughs.
Thank you. My last point is this: as we are dazzled by your work and the breakthroughs on cystic fibrosis and other things, we also face the grim reality that this great nation, this United States of America, maternal and infant mortality rates are absolutely unacceptable, particularly among some segments of our population. We cannot forget the basics here, and I know you aren't. And I hope that you'll be able to tell us, I've run out of time now, but in some other context, the work that is being done in these two particular areas.
I'd be glad to, for the record, give you quite a summary of all the things that are happening there, particularly supported by National Institute of Child Health and Human Development, which also covers maternal health. We agree that's a very high priority.
Thank you, Senator Durbin. Senator Moran.
Thank you, Mr. Chairman. Dr. Collins, thank you and your colleagues for joining us today and for the work that you and your team across the country do. Let me start with Dr. Lowy. Doctor, the President has proposed a pediatric cancer research initiative, safer treatments for children and better data. What can you tell me about the challenges we face in fighting cancer among children as compared to adults? Are there a sufficient number of children who are willing to participate in clinical trials? What are the issues that are unique to childhood cancers?
Thank you, Senator Moran. One of the most important things to understand is that children who have cancer are not just small people who have adult cancer, but childhood cancer is qualitatively different. Whereas adult cancer has many mutations, often there just are a few mutations that arise in children with cancer. In addition, while there's a tremendous amount of interest in cancer treatment for adult cancer, there is less involvement in the private sector, so that NCI has a particular obligation to do research in this area, and we have substantially increased the amount of research that we do in this area over the last few years. The particular proposal from the President is really along the lines of something that Senator Murray was asking about, which is how to efficiently and constructively aggregate data. And the goal, as we envision it, is to take pediatric cancer as an example where some of the information is still quite siloed. And by aggregating it and pulling it together with an interoperable system to be able to address important questions in pediatric cancer. Fortunately, in the terms of participation in clinical trials, a high percentage of children with cancer participate in that, and a lot of that is through the Children's Oncology Group sponsored by the National Cancer Institute. And because all childhood cancers are rare cancers, this is actually an international effort that is part of the COG.
Thank you very much. Dr. Hodes, we've recently seen a number of late-stage clinical trials focused on addressing Alzheimer's that have shut down, highlighting the difficulty in achieving meaningful progress in combating Alzheimer's. What is your view on the current state of Alzheimer's research? Where's the future potential? And maybe that's the questions.
Well, beginning with the failures in recent clinical trials, of course, all of us are deeply disappointed at them. And these are efforts that are generally been targeted at amyloid protein in individuals who already have symptoms. There are cases where there's very strong evidence to think that this amyloid pathway still may be important, in particular in some of the early onset familial cases, but also by targeting earlier in disease. And so we are pursuing those specific areas. But in addition, thanks very much to the increased funding that has come from Congress over past years, our understanding of the processes underlying Alzheimer's have improved enormously. Last year, for example, some 32 new genes were identified, more than had previously identified all around. This has led to the ability to identify from those genes, bioinformatics, systems biology, new targets. The number of targets is illustrated, Francis, if we actually have a visual to look at. This is meant to show at stages from drug discovery, drug development, to phase 1, 2 trials and phase 3 trials. Starting at the left, the early stage of discovery, each of those bars represents a different kind of target currently under study. And you can see the number of targets, whether it's inflammation or protein trafficking or proteostasis, that we're discovering more and more about as potential avenues. So the more targets we approach, the greater the probability in individuals with particular syndromes that we're going to have success. Out of some 35 clinical trials now ongoing, 13 are targeting amyloid, the rest at this multitude of targets. So a new generation of investigators, new science is leading us to this multitude of opportunities to make sure we have the way paved for a multitude of approaches to Alzheimer's disease.
Dr. Collins, the new set of scientists, the next generation, I can't think of the young lady's name on your screen years ago, but you highlighted her as somebody we're going to lose because of the instability in research funding. And while I suppose we're always looking for the concrete evidence that the funds have resulted in a cure or a treatment, perhaps at the between now and when we find all those cures and treatments, you can reassure me that the investment led by this subcommittee has made a difference in keeping, retaining, and encouraging young people to pursue careers in science and research.
Appreciate the question very much. Yeah, that was a young woman as a graduate student at MIT who was about ready to give up. That was a while ago. And look at this curve, which shows you our ability, thanks to you, to be able to ratchet up the awards that we've given to early stage investigators, that is, people who've not previously been a principal investigator on an NIH grant. In 2013, that was a little less than 600. Last year, we challenged all the institutes to try to really push this forward and get us to 1,100. We got to 1,287, by far the largest in history. We have made this a priority, and every one of those individuals represents somebody with a lot of energy, a lot of innovative ideas. This is the most important investment we could make.
Senator Shelby would have asked had he not run out of time, but on his behalf, I would ask if you would come to Kansas.
Yeah, thanks, Senator Moran. Senator Shelby.
I'm going to be on a lot of airplanes here, I can tell.
Well, thank you, Mr. Chairman, and Senator Murray for holding this important hearing. And thank you, Dr. Collins, and to all of you for the amazing work that you do. I want to begin with you, Dr. Volkow, because as I know you're aware, we have a horrible epidemic in this country of substance misuse, and in New Hampshire, we've been particularly hard hit. I appreciate your coming up and meeting with some of the folks in New Hampshire who address this challenge. Can you talk about what you're doing at NIDA that might give us some hope that there are additional medications, there are additional therapies on the way that might be able to help us address this epidemic?
Yes, indeed, and I think my microphone is not working, so can I borrow yours? Indeed, this has become an area of priority, and in fact, not just for NIDA, but for the whole NIH, and multiple institutes are working on it. So, and we have different strategies of research that are relevant to actually address the crisis. With respect to medication development, for example, it has been a unique opportunity to bring in the expertise from the NCATS Institute, the Translational Institutes, but also even from the expertise that comes from the NIAID Institute as it relates to the development of immunotherapies for addiction. There are some exciting projects that are likely to bring us more rapidly alternatives like extended release formulation that improve the compliance of patients with their medications. We're also very interested in developing new tools that can be more effective in reversing overdoses that we're seeing and people are reporting are higher to reverse when individuals are overdosing with drugs like fentanyl. In the field of expanding access to treatment, we now know, and we don't need to do any more research, that medications are extraordinarily effective in preventing relapse and in preventing overdosing and in preventing infectious diseases, including hepatitis C, or in outcomes in neonatal abstinence syndrome, but they are not being used. And the part of the problem is stigma, but another part of it is that we don't have sufficient infrastructure. So we are working with researchers to develop models of care that take into advantage the healthcare system on the one side and the justice setting on the other one. And these two systems have been almost like different universes. So we are using the funding that we're getting to bring them together and figure out how we can come with models of care that will treat the individual and sustain them in care. And then a third...
Which has been an issue in New Hampshire, as you know.
Yeah, no, and it is also a unique opportunity. We look at it in terms of preventing overdoses, targeting both of them. As well as taking advantage of, you just made me think, because New Hampshire has been incredible in terms of coming up with community solutions.
Right.
So my perspective is how do we learn from those community solutions so that we can apply them to other states? And we have an initiative called the Healing Communities that aims to do that. And finally, an extremely important aspect that we have to keep in mind when we're addressing the crisis is research for prevention. And why is that so? Because if we do not prevent, opioid use disorders, or we don't do interventions to prevent other addictions, we will be changing one for the other. So we have a very broad portfolio that covers these 3 different buckets.
Thank you very much. Dr. Rogers, as you know, diabetes is one of the most expensive diseases in this country, and I was very disappointed to see that the president's budget actually called for a $280 million decrease in funding for NIDDK. I wonder if you could, I don't think this committee will go along with that. I think we appreciate that investment in addressing diabetes research will help us in the long term to be more cost effective, as well as to address the challenge that folks with diabetes face. But can you talk about some of the breakthroughs that you're looking at now in terms of the artificial pancreas, which is really the most hopeful innovation to help folks with type 1 in particular?
Thank you for the question. Yes, the FDA recently approved, it's really been truly breakthroughs for treatment of particularly patients with type 1 diabetes, such as the first hybrid artificial pancreas and the next generation of continuous glucose monitors that no longer require a finger stick for calibration, or that those that are fully implantable. And I'm happy to report that NIDDK supported and the Special Diabetes Program has really contributed to testing of all of these FDA-approved therapies. And we really continue to approach this research at cutting edge in this area. We're supporting advances in artificial pancreas in 4 very large international clinical trials now, conducted both at academic medical centers and some using our special business funds to develop the next generation of management technologies. And I think the goal is to really provide the patient and their healthcare provider with different options to really decide what's the best artificial pancreas that could be used for that individual.
Well, thank you very much. I'm out of time, but I hope that our healthcare system and our health insurance companies will be willing to cover these kinds of innovations so people can actually benefit from them. Thank you.
Thank you, Senator Shaheen. Senator Capito.
Thank you. Thank you, Mr. Chairman. Thank you, Dr. Collins, and everybody for being here. The first question I was going to ask Dr. Collins, I think, has been asked a couple of times. We were really lucky to get Dr. Marie Bernard to come. Dr. Hodes was supposed to come, but doing what he should be doing with his family. And one of the doctors in the room, researchers in the room, expressed his concern about talented young scientists being frustrated with not being able to get into the queue. So you gave us the statistics of past had been 600 and now 1,287. Is that?
That is correct. That was for last year, and we're going to aim to make a very good result this year. We're already starting to count these up and make sure that any investigator who scores in sort of the top 25% as a first-time applicant ought to have a very good chance, a very high chance of getting funded.
Would you say those are geographically pretty much spread across the country then?
They are, as much as our grant portfolio is in general. And of course, there are institutions that send more grants and others that send fewer. And the IDEA program helps us by balancing that.
Right, right. Thank you. Dr. Hodes, we did have a great visit, and you were, as I said, well represented by Dr. Bernard. One of the things that we talked about during the visit to West Virginia University was the work that's being done with the other institutes at NIH in conjunction with NIA, with the National Institute of Aging, on different aspects of Alzheimer's. For instance, it was mentioned like a possible connection of low blood pressure and decreased cognitive impairment. Can you talk about what kind of coordinating you're doing at the Institute of Aging when you're looking and researching across the spectrum of NIH?
Thank you. It's a very important question, and a part of the success that we're going to have in addressing Alzheimer's disease or other complex problems, of course, to be to recruit the best talent from a diverse area of science and expertise. So along the lines of a previous conversation, over the past 4 years, about 1/4 of all of the awards have gone to new and early stage investigators. About 1/3 have gone to new to the field investigators who never even applied for research in Alzheimer's before. And last year, a particular program, for example, invited grantees of all institutes whose research was not Alzheimer's directed, but who proposed a supplement to bring their creativity, their technology, their genius to the field to do so, and last year awarded some 300 such supplements. This, we expect, and we're following up upon, will bring these people into the field. We directly fund the research on Alzheimer's and related dementias across all the institutes at NIH. So about $200 million last year actually supported awards to other institutes that are relevant to Alzheimer's and related dementias.
Yeah, I mean, I think that obviously brings an economy of scale a bit, but knocks down, I'm sure, like everybody else has silos. I'm sure NIH has had silos, not as many maybe.
Yeah, past tense. We hope to knock them all down, and we did pretty well, but we're still watching for them to try to come back.
Great, great. Dr. Volkow, as you know, my fellow senator from New Hampshire, I know you've been to West Virginia how many times now? 2 or 3 times, and thank you for that visit, those visits. The Naz babies, Lily's Place, and others, we don't know what the long-term effects of all of this is, I don't think, and I think a lot of it may be in the science of the person's, as the child grows, their own health, but there's always external factors that are going to be impacting this, what kind of education, family life, et cetera, et cetera. What are you doing with the NAS babies in terms of pharmacological research and specialized treatment strategies?
Yeah, and this is one of the priority areas for the HEAL initiative, to actually develop better treatment interventions that will improve the outcomes on the infants, and that will lead us to understand better what are the consequences on the one hand for a newborn that has, during pregnancy, their mother was taking opioids, right, but importantly, as they grow up in an environment where the mother may still be taking drugs and be subjected to a social deprivation. So on one hand, one strategy is, can we develop better treatments for neonatal abstinence syndrome? And we typically treat them, for example, with morphine. Mm-hmm. Now there is data that if you treat them with a small dose buprenorphine, you significantly decrease the number of days that they actually have to be given the medication. Just like we had also shown before that if you treat the mother with buprenorphine as opposed to methadone, you decrease almost by half the number of days that you actually, the infant that is born out of that mother will have withdrawal symptoms. We're also funding research, and again, this is in partnership with other institutes, including the National Institutes of Child and Health Diseases, about non-drug interventions. Mm-hmm. And this has emerged out of the root grass of communities that have had to deal with the problem. And for example, there's recognition now that physical contact of the infant with the mother could actually decrease the amount of morphine that is necessary to control withdrawal. So we are funding research to develop the evidence about what are the optimal interventions. And finally, as it relates to your question about what's going to happen with these children, there's been already some research that shows that in infants that are born out of mothers who were exposed to opioids, if you provide a supportive environment, those children grow up to not have evidence of cognitive impairments. Mm-hmm. But we are actually planning, in the planning phases of launching a very, very large study that will follow close to 8,000 infants as they go from infants into adolescence, to evaluate how exposure to drugs influences the brain developmental trajectories.
Yeah, I mean, that sounds very powerful. And the troubling part is it has to be a long-term study to be able to see the effect, and by that time the effect has taken hold. But thank you so much for your good work. Thank you.
Thank you, Senator Capito. Senator Langford.
Thank you, Mr. Chairman. Thank you all. Quick story. I was sitting on an airplane about 3 months ago, sitting next to a gentleman flying back to Oklahoma. He leaned over, introduced himself as a fellow Oklahoman, and we chit-chat for a while. And I said, "What brings you to Washington?" He said, "I come often. I'm in an NIH trial. And I have been for years." And he smiled and he said, "And I'm still here." And from watching his smile and chit-chatting with him on the 2-hour flight back home, it reminded me again of how many people that are still around, just like he said, because of the work that you're doing. So thanks for continuing that work and for helping folks that literally for him, as you know, he had been through everything to be able to get to your desk, to be able to get to that spot. So we appreciate it very much. Dr. Collins, give me an update on the brain mapping. I want to walk through several things we've talked about in the past. We've obviously made significant investments into that. I missed the very opening statement of this in a previous thing that I had to be able to get to as well this morning. Tell me where we are on brain mapping.
I'd love to talk about this. So this project, which began 4 years ago, has very ambitious goals to really understand what are the cell types in the brain. There's 86 billion of those cells, so that's a pretty big challenge. And how are they connected together? And how do the circuits in the brain do the amazing things that they're capable of? And how can that go awry and result in disorders like Parkinson's disease or epilepsy or a long list of others? We, after 4 years, I would say, have met or exceeded every one of the milestones that was put in place when the original plan for the 10-year program was put forward. And so you're asking the question, appropriate moment. Right now, we are having a meeting of all the brain investigators at the Marriott at Wardman Park. And this evening, I will chair a panel that will look at the plan now that's being revised. We can call it Brain 2.0 of what we might be able to accomplish given the platform that's already been built. It's exciting from what we've already learned in terms of new principles about how brain actually does what it does. It's exciting by the people that have come into it. In the latest couple of rounds of grant awards, more than half of them were engineers who would not necessarily be coming to NIH with grant applications, but they're fired up about this too. And that interdisciplinary part of this is part of the reason that I think it is turning out to be so successful.
Okay, thank you. We'll want to get a detailed update because we want to make sure it stays on track, obviously, but this is a massive project, as you detailed before.
Yes.
You have brought together folks from the outside and from private companies to be able to talk about alternatives to opioids and developing a non-addictive pain treatment. How are the outside groups, private entities, pharmaceutical companies cooperating with you? Is that group still together, still working?
Actually, quite well. We have, in fact, put in place a combination of scientific expertise from academia, from NIH, and from industry. And we are now trying to prioritize what may be as many as 60 or 70 possible therapeutics that would be non-addictive treatment for pain, but which have been slowly moving through the pipeline. We at NIH are setting up a clinical trial network for people with chronic pain syndromes so that these can be tried out in a rigorous way. And companies are willing to contribute those.
They are staying engaged.
They are staying engaged.
Okay, that was the risk at the beginning, to say you're bringing together competitor groups to be able to say we've got to sit down and solve this right now together. So
yeah, I met with the 20 pharmaceutical companies that have the largest budgets last weekend, and they were all on board.
Okay, thank you. Let me read a GAO report to you real quick, and I want to be able to get a follow from you. Their statement was they talked about VA, CDC, NSF, DOD, NIH, and they said each lack a comprehensive information on health research funded by the other agencies, which limits their ability to identify potential areas of duplication in the health research they fund. They made that comment just looking at the broad picture of all of the research that's happening in multiple different areas the Appropriations Committee appropriates. How is it working to be able to cooperate with VA, DOD, especially large programs, NSF, to make sure, because as you would know, grant folks are requesting of everybody. So they'll have a slightly different name for similar research and go to as many institutes as they can to be able to see if they can find money to do the research on it. How are we doing being able to avoid the duplication and communication in agencies?
So, Senator, it's a great question. It is something we're quite invested in. We have a whole office of portfolio analysis that's now been working at coming up with tools to allow us to look, very complicated research portfolios, what are the areas of overlap. We've done that kind of analysis, comparing NIH to NSF, comparing NIH to the DOD programs, comparing NIH to ARC. It's very informative to be able to see that in a visual form. And we have, in a few instances, identified places where there was duplication and acted upon it. We have not yet done this as much for VA, but that's next on the agenda. As long as we have access to the abstracts for the grants that are being funded, we can do this right away.
You're breaking down silos at NIH. The challenge is going to be for us to break down silos in medical research across multiple agencies to make sure researchers can meet with each other. And we know we've got similar research and we're sharing that information and we're not duplicating it. I will have a question for the record that I'll follow up with you. I know you had a interchange with Representative Harris on fetal tissue research. HHS is in the process of doing a review of all fetal tissue right now, and I know there's somewhat of a pause going on as they're waiting for that to be responded on, but I'll do some follow-up with some questions for the record with you on that as well.
I'll be glad to answer for the record.
Thank you, Senator Langford. We'll probably have a chance for a second round if you want to stay. Senator Baldwin.
Thank you, Mr. Chairman. Dr. Collins, you and I share a passion and a personal priority of investing in our nation's next generation of researchers. I think most everyone on the subcommittee knows from my retelling the story that I was raised by my grandparents, and my grandfather was an NIH-funded scientist, a biochemist. And so I grew up understanding the importance of the contributions of our researchers to biomedical leadership. In 2013, I had a particularly powerful meeting with a high school student. He was a bone cancer survivor from Fond du Lac, Wisconsin, and his name is Ian. And Ian told me that cancer research helped save his life. He decided at that point that he wanted to grow up to be a scientist and to help others who had the disease. But he was concerned that it wouldn't be possible for him to break in as a new researcher due to NIH funding cuts. Ian inspired me to author the Next Generation Researchers Act with my colleague Susan Collins to improve NIH opportunities for our new and early stage researchers. I am proud to report to you that Ian has graduated from college and is now working in a lab with a scientist at Huntsman Cancer Institute in Salt Lake City, Utah, studying pediatric cancers like osteosarcoma. I applaud NIH's progress in implementing my Next Generation Researchers Initiative to help support future scientific leaders like Ian. In fact, as you noted, NIH funded 1,287 early-stage investigators in 2018 as part of this work, the largest number in history. I would love it if you could elaborate on NIH's work to implement this initiative since it was signed into law back in 2016, and your plans for implementing it moving forward, and any comments you might have about the National Academy's consensus study report on the next generation of biomedical and behavioral sciences researchers.
Well, Senator, I really appreciate the way you have drawn attention to this critical issue, and we've named our initiative the Next Generation Researchers Initiative after what you authored, because we were totally in sync with this as one of our highest priorities. When Ian asked you the question, how we were funding, according to the graph here, if it was 2013, less than 600 early stage investigators, and that was a time where it was challenging for somebody trying to get their career started to have confidence that there was going to be a path forward. Notice what has happened since then, thanks to the strong support of this committee and to our prioritizing early stage investigators as the most important applicants that we see. And yes, we are now in 2018 up to 1,287. We aim to try to keep a level in that space going forward. I think that's a pretty healthy number. This is not one of those where we want to go up and then go back down again, because there's plenty of remarkable talent out there. So in addition to, of course, trying to be sure that we are doing this in a fashion that attracts really talented people, we also are focused on diversity. We want to have more women in this category because we still have not achieved a point where our grantee pool is what it could be, given that PhDs now are being granted 50-50 to men and women, yet we still, as first-time applicants to NIH, it's about 30% that are women. We're coming up with ways to try to make this pathway seem more appealing and for us to be more welcoming. And of course, that means dealing with the sexual harassment issues that Senator Murray rightly brought up earlier. We did support that report from the National Academy, and we have a strong agreement with many of its recommendations in terms of what we need to be doing to sustain this. But as I briefly said earlier, I am perceiving, and Ian is a great example, of a good deal of a change in the enthusiasm and excitement out there in institutions of young graduate students, postdocs, junior faculty who really see, okay, this is a good time to be in science, not a time where we have to worry about our future quite as much as we did 5 or 6 years ago. So thank you for the way you've supported this.
Well, thank you. I've been concerned that President Trump's budget would cut NIH funding by over $4 billion, as years of budget cuts are one of the primary factors in discouraging, historically, young scientists from getting into the field. or forcing them to leave the field to pursue careers in other countries or in other realms. Yet no investment in my mind promises greater returns for America than our investment in biomedical research. Will the Next Generation Researchers Initiative deliver on its promise and be able to continue to hit such ambitious milestones as you're describing under the administration's proposal to reduce overall funding for the NIH?
Well, of course, everything we do depends on the overall support that we have available. This Congress and this particular subcommittee has been very attentive to that, and the opportunities that we've had over these 4 years of seeing our budgets go up by a total of 30% have made a lot of these things possible. We always, though, have to adjust based upon the resources that we have. I will tell you of the institutes at this table and the others who are not here, this funding of early stage investigators is one of our highest priorities. We will seek to make that happen to the level that we can with the resources we've got.
Thank you. And Chairman Blunt and Ranking Member Murray, I oppose the President's budget request to slash funding for NIH, and I look forward to working with both of you to increase funding both for NIH and for a special focus on the Next Generation Researchers Initiative in the fiscal year 2020 budget.
Thank you, Senator Baldwin. Senator Alexander.
Thank you, Mr. Chairman. Dr. Collins and your team, welcome. First, I want to once again salute Chairman Blunt and Senator Murray and others who have worked over the last 4 years for such steady progress in funding for the National Institutes of Health. And one reason we've done that is because we had such great confidence in your leadership and that of your team that you'd spend the money well. So it's a testimony to you and very important. In the opioids legislation, we did something that you had asked us to do when we talked about 21st century cures. That was to give you other transactional authority so you could deal with such things as a non-addictive pain medicine. We, in the committee that Senator Murray and I are ranking on, we recently held a hearing on pain, and that that reminded us that when we limit the supply of the most effective pain medicine, opioids, to millions of Americans, that causes a lot of worry among people who live with pain every day, and there are millions of them. So my question is, what have you been able to do with the other transactional authority that we gave you to help find new non-addictive painkillers?
It was very helpful, in fact, essential to have that kind of authority to move quickly in this space of putting together an unprecedented public-private partnership to try to speed up the development of those non-addictive pain medicines. As I mentioned a couple minutes ago, we are working now with pharmaceutical companies who are willing to put forward compounds. We're calling them assets, but basically they're untested drug compounds that are ready for clinical trials but have been slow moving through that pipeline. We then need to do a very quick review of how to prioritize these. We can't test 60 of them, but we might be able to ultimately run trials on a dozen or so, which means we need to have a process of review that is very streamlined, and it needs to be supported in a way that would be very hard to do with a traditional grant mechanism. The other transaction authority is exactly the tool that we have needed in that space. It has been essential, and so we're grateful for it.
Well, I have an even higher sense of urgency about the non-addictive pain medicine and treatment and the accelerating our effort for that. Let me go back to April of 2016. You testified before this subcommittee and made 10 bold predictions of what might be able to happen in the world of medical miracles over the next several years. A lot of them are happening, and you've mentioned them today. Are you ready to update your 10 bold predictions for the next 10 years?
I probably could do that. It would be kind of fun because there were some things that I don't think I put down in 2016 that I could now be pretty enthusiastic about. So, for instance, in 2016, I don't think I would have been bold enough to say that we would be curing sickle cell disease. And yet we are now seeing in at least 3 clinical trials that NIH is supporting examples of individuals who are
cured. Is that because of CRISPR?
CRISPR is in there, and other kinds of gene therapy making this possible. Some of the things we put down at that point I thought were a bit like overly optimistic, and yet maybe I underestimated how quickly things would go. We earlier talked about the artificial pancreas, and I put that one down, and a year later,
That's pretty
FDA approved
common,
the
right?
first one.
Well, what about regenerative medicine? The juvenile diabetes folks say that the next step is regenerative medicine might help actually change the cells so you wouldn't have to use a device. Is that possible?
I think that is the ultimate goal. Maybe Dr. Rogers would like to make a quick comment to go from what's currently a technology that's like a servo mechanism with some non-human materials into a human version of an artificial pancreas derived from stem cells.
But the impact of that would be astonishing, wouldn't it?
Profound. And it would be your own cells, so you wouldn't. This isn't a transplant; it's a basic.
So you wouldn't
correction.
have to prick your blood for your blood every day. How would that work, Dr. Rogers?
Well, that's a great question. So cell replacement therapy is certainly an area that we're also, in addition to the artificial pancreas technology, to look for a curative therapy with a curative intent. The goal here would be to stimulate the person's own beta cells, those cells that are lost due to the autoimmune disease, and get them to replicate, to expand them, or alternatively, some of the remaining cells, such as the alpha cells that make glucagon, trick them into actually becoming beta cells so that the insulin can then be produced as well. One thing that we're doing in that space, using these islets, for example, the cells that make the insulin, is actually putting them on a chip. And I actually have brought a copy of one to illustrate for the committee. These islet cells are put on this chip together with cells that replicate the pancreas environment, blood vessels, as well as components of the immune system. And in that, you have, in a sense, you can mimic the disease on a chip. What the potential of this is that we may be able to test therapies in advance and save some of the money and expense and time associated with testing novel technologies in humans and get those that are likely to fail out of the way. And so we really have a lot of enthusiasm about this type of work.
My time is up, but I look forward to your updating your bold predictions, Dr. Collins.
You're on.
All right, we'll look forward to the list of bold predictions. Dr. Fauci, I'm going to take 5 minutes here, and I've got 3 questions. Maybe we can deal with all of them in 5 minutes. One is measles. What do you think is happening, and how concerned we should be about it? 2, the antibiotic resistance, the fungus that we're having big problems in a couple of places in the country now. And then 3 would be the president's HIV 10-year prediction to not have transmission or not have this as a problem anymore. So start with measles.
Thank you, Mr. Chairman. Measles is really a formidable problem that is growing. It's a completely avoidable problem, which is the reason why we in the scientific and public health field are so frustrated by it. If you look at the year 2000, we here in the United States had essentially eliminated measles. By elimination, it means that there are no transmissible cases in the country over a 12-month period. Yet over the last several years, there has been increasing numbers of cases of measles, and I'll explain in a moment why that is occurring. The problem right now, this past 3 months of 2019, we've had 465 cases of measles in the United States, which is more than we saw all of last year. And the cause of that is very clear. It's individuals in the community who are not vaccinating their children, leaving a vulnerable group such that when someone comes in from the outside, from another country where measles might be rampant, and into the community, that if you have that veil of protection that you need when you need a certain critical percentage of the population is vaccinated. And for measles, that means between 93 and 95%. But look at what's going on now in the state of Washington, in the Rockland County, New York, and very, very importantly, in the middle of New York City, in the Williamsburg section, where the Hasidic Jewish community goes down to around 70% protection, which means that veil of community immunity is gone. And that's the reason why we're having this outbreak. It's very frustrating because measles is one of the most transmissible viruses known to man. And we have a vaccine against measles, which is one of the most effective vaccines known to man. And yet those two are not coming together with this
hesitancy to get vaccinated. So our goal and our purpose now is to try and educate people to understand the importance of not only protecting their own children, but protecting the community. That's measles. The fungus that you alluded to, it's called Candida auris. Fungi in general that we see are mostly, I wouldn't say benign, but relatively easily treatable. The problem with this fungus that has now come out, about 500 or so cases, is that we're seeing in hospitals particularly a fungus that's rather resistant, if not completely resistant, to the antifungal agents. This is particularly important for individuals who are immunosuppressed, people on cancer chemotherapy, or people who have underlying immunosuppression. You've read about it in the front page of the New York Times that this is becoming a problem that we have to address, and it falls under the big umbrella of the antimicrobial resistance. Third, the president's announcement at the February the 7th State of the Union address about ending the HIV epidemic as we know it in the United States. And this is based on something that's happened for many years, largely supported by this committee, is the development of the tools to do just that. We have drugs right now, as you well know, I've spoken to you about this, that if you treat an individual who's HIV infected and bring down the level of virus to below detectable level, not only do you save that person's life, but you make it essentially impossible for that person to transmit the virus to someone else. And then there's pre-exposure prophylaxis, or PrEP, which means that if you're at high risk of getting infected and you take one pill a day, you can decrease by 97% the likelihood that you actually will acquire infection. You put those two things together and you look at the map of the United States, why it's so unique. We have 3,007 counties in the United States. In 48 of those counties, plus the Washington District of Columbia, plus San Juan, more than 50% of all the infections in the United States come from that very restricted group. So the plan is to take this demographically and geographically concentrated area and, as I say, put a full court press on getting into the community and implementing each of those. So I'll stop there and I give you back 10 seconds.
Well, that's back to the observation earlier that you've testified before. You can take 3 questions, exactly time them out, and land on time. Senator Murray.
Thank you very much. And Dr. Collins, I know you're aware of a recent study in the Journal of American Medical Association which found the gender differences, you talked a bit ago about that, in the amount of NIH funds awarded to first-time female and male principal investigators that favored men receiving larger grants than women. And data shows that in academic medicine, which for years has trained just as many women as men, the percentage of women in the workforce decreases at every career stage, such that women make up only 25% of the professorate. And your conversation with Senator Baldwin indicates you're aware of a study that also found that women held fewer grants, submitted fewer applications, and were less successful at renewing grants than their male counterparts. So in light of the National Academy's report last summer, which showed that sexual harassment is rampant in academic science and undermines women's professional attainment, in some cases leaving women to leave the scientific workforce entirely, the cumulative effect results in a significant damage to research integrity and a considerable loss of talent in our country. So aside from its economic and potential scientific impact, that loss of talent actually represents a significant cost to our taxpayers. It has been estimated that each newly minted PhD costs $500,000. And of course, it's a personal loss to women who feel pushed out of a field they love. So given all of that, can you comment on actions that NIH is taking to address this attrition of women from the biomedical workforce?
I'd be happy to. This is a very critical issue, and there are multiple factors, but certainly the realization of how prominent and pervasive sexual harassment has been leads us to push even harder to address this issue. It is unacceptable, it's morally indefensible, and it drives talented women away from the workforce who could make wonderful contributions. if you look at this graph that sort of shows you what's happened as far as the percent of various types of grants that are going to women, you can see in the career awards, which are generally people early in their independent phase, we are doing better over time. We're actually doing better with research project grants, but this curve is way too slow in terms of its upward movement. That ought to be 50%. And it's not that there is a discrimination against women who apply for grants. If you look at the likelihood of getting funded, men versus women, it's almost exactly the same. The problem is we're not getting the applications.
They don't apply.
And that is clearly an indication that there's something about our environment that is not welcoming. It does not feel like, to many women, a place they really want to be. There are lots of factors in there, in addition to the sexual harassment issue. There are family issues. There are the issues about who has responsibilities for other parts of the community that people are coming out of. There is this sort of concern that if you look around, where are the mentors? I believe we really need not just to try to address the things that are most egregious as far as the sexual harassment, but also the gender harassment, the way in which our culture encourages women oftentimes to think they don't belong there by subtle comments that are made usually by men. We have to change that. The best way to change that is to get more women into leadership positions. In our
I'm looking at your
intramural
panel. It's great, but...
Yeah. Well, yes, look at our panel. Just take a snapshot here. This is a good example of what we need to change. We're actually looking at our intramural program right now to try to see, are we doing enough there to provide opportunities for talented women to rise through the ranks, or are we too ossified by people who get into a position and stay there too long? We're taking this with great seriousness. I grant you we should have done so sooner, and I'm apologetic to those who think we have not done enough. We're determined to do better.
Okay, I appreciate that. Thank you very much. And of course, we all have to participate, and appreciate your taking this seriously. Look forward to working with you on it. I think we're losing talent from an early age, and it gets worse as we go, and we've got to make sure we have all of our talent at the table. So thank you.
I agree with you.
Dr. Volkow, my last question. There's a lot of hope in my home state that opioid-related overdoses may have peaked, and but we have been seeing an alarming increase in methamphetamine overdoses now. And as you know, there's no FDA-approved treatments for methamphetamine dependence. Can you tell me what NIDA's efforts to develop treatment for methamphetamine addiction is right now?
And you're asking me a question that actually literally makes me extraordinarily anxious and keeps me awake at night, because you're seeing the numbers of mortality increasing for methamphetamine and cocaine too. Mm-hmm. And we, even though we funded research to come up with treatments, none of them have reached the outcomes that are actually necessary to get them approved and show them effective. However, what is very exciting in the whole area and possibility relates to immunotherapies, and in fact, where we've done the greatest advances in developing monoclonal antibodies for capturing the drug so that the drug gets sequestered in the blood and never gets into the brain, obviating any pharmacological effects, happens to be for its application on methamphetamine. So we've brought those antibodies already into humans, and what we're trying to work right now is the extent to which, by partnering with some of the scientists that are part of the NIH Institute and the Cancer Institute on developing longer-lived monoclonal antibodies, the extent to which we could apply them. Because they work, they capture it. The problem is that they are not long-lasting, so you have to repeatedly immunize. So this is one of our priorities as it relates to medications. In parallel, of course, we are funding research in terms of behavioral interventions to try to actually improve the outcomes on individuals that are suffering from methamphetamine addiction.
Okay, thank you very much. I really appreciate it. And thank you to all of you for being here today. I appreciate the great work you do.
I have just a couple more things as we finish up here. Dr. Lorsch, we talked about young researchers. I think you've also been experimenting with longer research times. Would you talk about that and talk about whether there's any impact of that your appropriation stream has on being able to do that?
So thank you very much, Senator. We have developed a new program called Maximizing Investigators Research Awards, or MIRA, which has several goals, but one, as you said, is to give a longer and more stable funding stream to investigators. And we hope that by doing that, and by also giving them more freedom to basically follow their noses as their research evolves, we will allow them to do more ambitious research and to get faster to discoveries through this process. There are two parts of it. One's the established investigator part, and the other is the early stage investigator part. The early stage investigator part is actually particularly exciting right now because since the program started in 2016, we've seen a doubling of the number of early stage investigators that we fund at the Institute, primarily through the MIRA program. We've seen a 60% increase in the number of applications from early stage investigators, so they're clearly speaking with their feet that this is the way they want to see science supported. And what's particularly exciting is we're actually funding them at a younger age. So all 3 years of the program, the median age of funding for early stage investigators in MIRA is 37, whereas it's 38 for early stage investigators funded through R01s. And we're hoping that trend is going to continue. And what I'll say for the record is that one of my strategic goals for the Institute is to try to push that age of funding for MIRA down to 35. I think 37 is still too late to be getting your first grant award.
Well, thank you for that. Dr. Volkow, we've had this 30% increase in NIH we're all pleased about. During that same period of time, we've had a 1,300% increase in money going to the opioid fight. I don't know that we've talked yet today about, I think maybe your last answer touched on alternative research to have pain medicine that's not addictive. Do you have any more you want to add to that?
There is two components to it. One of them is in terms of the basic science that Francis was speaking, that allows us to identify completely novel treatment targets, molecules, or immunotherapies actually for management of pain. And then those interventions that don't rely in biologics or medicine, and that includes behavioral interventions to evaluate the extent to that they can improve the outcomes, as well as an area that's very exciting in the whole area of brain diseases is the use of neuromodulation technologies like magnetic resonance, transcranial magnetic resonance stimulation, or direct electrical stimulation to modify certain areas of the brain in means to actually improve outcomes. And the research, for example, there are several papers that have shown positive effects for various chronic pain conditions that offers an opportunity. There is also, as part of the HEAL initiative, a project that is going to be evaluating comprehensive models of care, just as the CDC recommends for the management of chronic pain, that will determine the extent to which they are effective and optimize and our understanding about what are the active ingredients and how to sustain them. And two, at the end, recognize that chronic pain is an extraordinary difficult condition to treat, and that it's heterogeneous, and that we may require to do what is done in cancer, personalized intervention. So doing the research that will enable us to get there will be very important in helping patients suffering from severe chronic pain conditions.
Just want to weigh in for a minute here and say how incredibly helpful it was for the Congress to identify this as an area both of great need and of great opportunity. And the $500 million that you put into the budget beginning in FY18 has made it possible for us to solicit truly bold ideas across all of NIH. We now have 20 of our institutes engaged in this, more than 40 different funding opportunity announcements, some of which have already received grants, have been reviewed, and are starting to be funded, some of which are still out there for solicitations. By the end of this fiscal year, we will have put the largest infusion of research into finding non-addictive alternatives for pain that's ever happened at NIH, in addition to funding a very large amount of efforts to try to help how to manage opioid use addiction, which is obviously our national crisis. We couldn't have done this at this scale without your help, and it's made all the difference.
Good. I don't remember the first time I noticed that the cause of death was sepsis. It doesn't seem to me it was that long ago, but it does seem to me that I see that often now. What are we trying to do there, and is that an NIH issue that you're dealing with?
It is. Maybe I ask Dr. Lorsch to say a little about the basic science part, and Dr. Fauci about the clinical efforts, because all those are hand in hand.
Right. Thank you very much. Sepsis research is supported jointly by three main institutes. One is NIGMS, one is Dr. Fauci's institute, NIAID, each of which fund about a third of sepsis research, and Heart, Lung, Blood funds about a quarter of it, and the remainder is Child Health and Dr. Rogers Institute. I became concerned a couple of years ago that the pace of research in the basic part of sepsis, understand the mechanisms underlying the condition, wasn't fast enough. So I put together a working group of our advisory council, which right now is examining our portfolio and the field and how it fits in with the rest of what NIH is funding. And they'll be making recommendations to us at the May council meeting that we'll have next month. Particularly, they're going to be looking at the balance of research in animal models versus in humans. We're concerned that perhaps there's too much emphasis on looking at sepsis-like conditions in mice and not enough in the actual human condition. And we're also looking at ways we can leverage clinical trials networks that are funded by other institutes that are already enrolling critically ill patients who may develop sepsis. And perhaps Dr. Fauci wants to say a little bit about that.
Thank you, Mr. Chairman. The effort against sepsis, as Dr. Losh has mentioned, is really multifaceted because you have a microorganism, a pathogen, that triggers a process that is a physiological and pathological process that leads to what we now know as sepsis. It isn't just the microbe, and it isn't just the response. It's a combination of the two. NIAID's role is to study specifically the microbe itself, the virulence of the microbe, the processes that trigger these physiological and pathophysiological events, as well as treatment. And as Dr. Losh mentioned, we have a clinical trials network that we look at these patients. It's very difficult to actually study them because when they come in, it's such an acute situation that you have to move very quickly when you're doing a clinical trial. But we're working with other institutes, including the National Heart, Lung, and Blood Institute, to do this kind of synergy of multiple approaches to what is a very complex and heterogeneous problem.
Well, we're about to, Senator Murray, we're about to finish here. Is there anything we should have asked that we didn't ask?
You did a pretty fine job of covering a lot of the landscape with the folks who are here. And again, I have to say how much it has impressed me over the years about how much the members of this subcommittee have become so deeply knowledgeable about what we do. So these conversations always end up being full of really rich details and digging into areas that we love to talk about. So many thanks to you for all of the ways in which you have spent your time on these issues. And of course, we would love to invite you back out to NIH at any time because we always have new things to show you.
All right. Well, we hope to come out sometime before too long. The record will stay open for 1 week for additional questions, and the subcommittee stands in recess.
So exciting. I actually have to run. I don't want to be rude, but I have to actually do a AAAS interview at 1 o'clock, so I'm going to try to get back to make it. Yeah, I have an interview at 1, but not all the way up the mountain. It's really, and it was so, because I hadn't heard it. It was like a great time to run.
Absolutely, thanks.
And my brother is
No, it's the first time around. Awesome. Thanks again for being here.
I'll email you. It's okay. Great. It was good seeing you. I have no guilt telling everyone I work.
And I'll see Rod at the advisory council meeting. Yeah, I don't know. So you guys don't know each other, so this is gonna be. Yes.